Our next speaker is Aoife Carolan from St. John of God Hospital. And Aoife is doing a presentation on applying quality improvement methodology to the discharge process for older adults in a mental health setting, an interprofessional, person-centred approach.
Thank you. Good afternoon, and thank you for the opportunity to present our research today on applying quality improvement methodology to the discharge process for older adults in St. John of God Hospital. It's an interprofessional, person-centred approach. I'm presenting today on behalf of a multidisciplinary team of pharmacists, doctors, nurses, administration staff, and occupational therapists, and our affiliations are listed here on the title slide. It is well recognised that advanced planning and good communication between older people, their families or carers, and healthcare professionals is required to improve the coordination of care at discharge from hospital. As part of the Global Patient Safety Challenge, Medication Without Harm, the WHO has asked countries to prioritise medication safety in transitions of care. Discharge from hospital is a high-risk process and can be associated with medication errors. 25 to 80% of patients have at least one medication discrepancy or failure to communicate medication changes in hospital at discharge. In April 2020, legislation changes permitted the electronic transfer of prescriptions in Ireland. This created opportunities for seamless transfer of prescriptions on discharge from hospital. We wanted to make sure that this opportunity was utilised and applied in a safe and effective way in our setting. In healthcare service provision, quality improvement methodology is one way we can deliver sustained improvements, not only in the quality, experience, productivity, and outcomes of care, but also in the lives of people working in this setting. Quality improvement methodology has been adopted in healthcare settings in Ireland and in St. John of God Hospital in recent years. It has been successfully applied to areas in St. John of God Hospital, such as the admissions process, care planning, catering, and the process for requesting blood tests. Collaborative practice happens when people working in healthcare settings from different professional backgrounds work together with patients, their families and caregivers, and communities to deliver the highest quality of care across settings. The aim of our research was to apply quality improvement methodology to the process for discharging older adults from St. John of God Hospital in a collaborative approach. This is quite a busy slide, but quality improvement methodology was applied to the process for the transfer of discharge prescriptions in particular. We used the DMAIC framework, so this stands for Define, Measure, Analyse, Improve, and Control. We defined the current process, we measured for defects, and those were errors or wastes in the process. We analysed the causes of those errors or wastes. We then sought to improve the process and then control the process so that errors or defects did not recur. We took an interprofessional approach to this DMAIC process and we enlisted a multidisciplinary team. So from the slide here, it's not really possible to see clearly, but the process map on the top left-hand tile, that's the define phase. So this involved process mapping the existing or current process. We identified all of the steps involved in discharging a patient, and from the point of deciding to discharge the patient to the transfer of the prescription to the community pharmacy. We described or mapped all of the different steps in this process. In doing this, we discovered significant variation between teams and settings. For example, inpatient and outpatient systems worked a little bit differently. We established how the current process impacts the various different stakeholders. So we spoke to the secretaries that were involved in the process and all of the different stakeholders. And we also spoke to community pharmacies, who were the last person to receive the discharge prescription, and we understood how our process was impacting those stakeholders too. We then measured the existing process. So we looked at the turnaround time from the decision to discharge a patient to when the prescription arrives in a community pharmacy. We measured the number of errors or defects in the process. So that would be a prescribing error, or an error in communication, or an extra telephone call would be considered an error because the initial process didn't work fully. We presented the defects or errors as DPMO, which is defects per million opportunities. Then we looked to analyse the causes of these errors and the structures that we had in place that led to such errors. So that's the fishbone analysis on the bottom tile there. We identified the contributing factors to errors or defects. We identified variation in the process leading to delays or inefficiencies in the current process. We used the fishbone analysis for this, and we were able to chart the different environmental factors, such as a busy ward environment or a busy dispensary, different equipment factors, such as the lack of scanners maybe at the point of where you write the discharge prescription. There isn't a scanner necessarily available, so that led to errors or wastes in the process. A lack of standardization in the methods led to confusion, lack of knowledge of the process, and maybe lack of awareness of the current process led to issues. So using the data obtained from the define, measure, and analyse phase, we hoped to be able to make improvements in the process, and we would also then control the process to make sure that the newly improved process did not allow for any errors or defects to recur. So these are our results. DMAIC revealed significant variation in the current process. 100% of prescriptions were handwritten at the point of discharge, and only 82% of those had been scanned onto the patient's record or their electronic file. This meant that they were not always visible for future visits in the outpatient setting, leading to potential for errors in prescribing. 22% of discharge prescriptions contained a prescribing error. The defects per million opportunities, or DPMO, was 226,600, and sigma was calculated at 2.25. The mean turnaround time from the decision to discharge a patient to the prescription arriving in the community pharmacy was 11 hours. Less than 50% of prescriptions were clinically screened by a pharmacist, which might explain some of the errors and the defects in the current process. So a new standardised process was developed. To utilise the current electronic system that we had, we created a new electronic prescribing and an electronic prescription template. And this allowed us to electronically prescribe at the point of discharge, and we then utilised the new legislation which allowed us to electronically transfer these prescriptions. Interdisciplinary working between the medical and pharmacy teams improved medicines reconciliation at discharge to 100% of all discharge prescriptions. They were clinically screened by a pharmacist. 100% of discharge prescriptions with the new process were electronically typed, and handwriting or legibility errors were reduced to 0. The mean turnaround time was reduced from 11 hours to 2 hours. Secretarial time in the process was reduced to 0. And the DPMO, the defects per million opportunities, was reduced to 52,100, and sigma improved to 3.12. Throughout every step in this process, we made sure that the patient was at the centre of all of the decisions that we were making. We were very conscious that this new process, as efficient as it was, allowed us to bounce a prescription from a computer in the hospital to a computer in a community pharmacy, bypassing a lot of additional and unnecessary steps. However, we had to make sure that we weren't bypassing the patient in the process. So person-centred care incorporates shared decision-making, self-management support, care planning and co-production. And it is important in mental health services because person-centred care has been found to increase engagement, improve medication adherence, improve well-being and reduce symptom severity. So in our process, interdisciplinary working between the occupational therapy and pharmacy team resulted in the joint provision of a discharge planning group. Medication in My Recovery is now a formal part of the discharge planning group, and pharmacists attend this group each week to discuss the older person's needs and their preferences with regard to medication at discharge. Psychoeducation and provision of information with the aid of a My Medicines list is now facilitated by the team pharmacist in collaboration with the team occupational therapist to ensure that the patient is still involved fully in this process. So in summary, quality improvement methodology was used to develop a new process for the electronic transfer of discharge prescriptions in St. John of God Hospital. Interprofessional collaboration between medical and pharmacy staff reduced the turnaround time and medication errors at discharge and increased medicines reconciliation to 100% for all discharge prescriptions. Interdisciplinary working between the OT and the pharmacy team resulted in the joint provision of a discharge planning group and improved patient involvement in the discharge process. We also have some accrued benefits. So we now have established a list of essential specifications for the new fully integrated electronic health record system. So having applied quality improvement methodology, we now know exactly what is required from all stakeholders for the discharge module for a new fully integrated electronic health record. Thank you for your time this afternoon, and I'd be happy. I'm happy to answer any questions.
That was perfect timing as well, by the way, just before it went off, so brilliant. Anybody any questions? Yeah?
What number of patients are we talking about? What number of patients would you have included in that particular study?
So this was a pilot study carried out over 2-month period. On average, there was 3 discharges a week. So
anyway, fantastic results. Well done.
Thank you.
Anyone else got any questions? No? It's fantastic.
How do we sustain it? So this was just in the older adults group, so we need to get some engagement from the stakeholders across the rest of the hospital. I think one of the key, the most important things that I learned from this was that teamwork was essential. You can't go in and make a quality improvement project with just one discipline. It has to be collaborative. So in order to sustain it, it's good to have champions across all of the disciplines to make sure that that project could be sustained. And I think if people can recognise the benefits, and I think one of the important things with quality improvement is that it improves the lives and the experience of people working in that setting as well. So if you can manage to get that message across and people then see the benefits, then they're happy to continue it.
Presumably you can replicate it across any kind of acute to home setting.
Yeah, in St. John of God Hospital, we can replicate it across the different teams. That's the plan. Once we started off with the pilot on one team, we can expand it across. But there is
outside that, could it be rolled out in HSE or, you know?
Yeah, so there is a drive for electronic transfer of prescriptions and electronic prescribing across the HSE. There's differences in the software that's used, but HealthMail should, in theory, be able to allow for community pharmacies to receive electronic prescriptions from. But there's the logistics of the actual electronic system that you're using as well. So it's not possible to standardise it across every setting.
And could I ask you, the group that was, I think it was pharmacy and OT.
Yeah.
So how did you organise that? Was it anybody who was leaving that week took part in the group, or?
So yeah, once we have a discharge date identified, we've asked for the pharmacists that work in. So the pharmacists and the occupational therapists that have patients on the older adult team. So at the moment there's 3 teams in St. John of God Hospital. The pharmacists and occupational therapists can refer once a discharge date or an estimated discharge date is known. And generally it's a couple of weeks before they actually go home. So they can then attend the group, get the information and Often there's a couple of questions or a couple of follow-up actions after the group from the OT or from the pharmacist. But yeah, so it's referred by the pharmacist or the occupational therapist. Yeah.
Thank you. Any other questions? Okay, thank you.
Thanks.